the Vasomag team. A great idea, great meeting, enjoying it thoroughly so far. So, atherectomy and DEB, marriage made in heaven. I think Casey just proved that this marriage has been made in heaven, and let's see how long these marriages last. So, like all marriages, it's not all made in heaven. Some of it requires some therapy to happen alongside it. So, for the younger people in the audience, so the limitations of DEB is that yes, it's just a balloon by itself, and the purpose of that balloon is to try and achieve luminal gain, and the purpose of drug on it is to try and maintain long-term patency. But you still deal with the problems of elastic recoil, dissection, acute closure, and the fact that a balloon does not work very well in heavily calcified lesions, and that's the whole principle of this, which is where you marry in the other technology of trying to achieve luminal gain. And the principle of atherectomy is that you're using a sharp knife or a hard knife against an area which has got soft tissue and hard tissue. The soft tissue doesn't get sliced, the hard tissue gets cut through. That's the essential principle of atherectomy as to how it works. And multiple types of atherectomy. In fact, just now when Casey was saying he used the stealth device, I didn't know what the stealth device was. I had to actually Google it to see what bloody kind of thing it is. There are so many different devices. It's confusing. So let's be honest about this. I'm going to ask Vivek difficult questions as president of BSI on all of these later on.
Scientific coordinator.
But essentially, you've got these different kinds of atherectomies, the directional ones, the rotational, the orbital, and the laser ones. And that's the broad groups. Now, these, again, classifications of these, and these had been shown before. So I'm going to just run through this atherectomy bit a bit quickly, but I think it's just good to know what you're dealing with over here. So Medtronic has got this Hawk series, the Silver Hawk, Turbo Hawk, and the Hawk 1, and the different generations of it. So the Silver Hawk is essentially a directional cutter for soft to mild plaque while it's actively retrieving whatever you're cutting out. The Turbo Hawk has got a high efficiency model and a lower efficiency model, again for mild to moderately calcified lesions, but you need to use a filter. And remember, this filter will keep appearing when you look at atherectomy because you require embolic protection device. The Hawk one is a directional one, so good for eccentric plaques like Vijay was saying earlier. And remember, none of these devices are actually licensed for use in the iliac or the renal or the aorta. So that's, you don't want to be sticking these atherectomy devices in there and landing into trouble. So these are all for SFA and below. The rotational atherectomy is essentially like a drill bit that you're shoving into the vessel and getting it to spin and drill a hole through that. The BD, so this is the Boston rotablator, and essentially all of them got a diamond-tipped burr head which kind of drills through the stuff. And you can imagine when you're drilling through things, what's happening, you're sending a shower of material lower down, which you need to keep aspirating out or filtering off. The Rotarex is the BD one, which actually has got an interesting story behind it because the guy who manufactured this device, who actually created it, was an industrial engineer who manufactures massive connectors for ships' plumbing. So he does specialized manufacturing of very high-end plumbing devices. He developed PAD. He went to the University of Zurich, where he ended up getting his angioplasty done. Zurich is the same place where the first coronary angioplasty was done, which is where I heard the story about Grunzig being chased out of the university. So he went there, he had an angioplasty, and he said, this is a terrible procedure. You left behind all my disease, and I haven't had any good result from it. So the vascular surgeon was his friend. He said, this is the best we've got. You're an engineer. Why don't you come up with something? So he then sold off his company, opened up another company, which was Straub Medical. So Straub was the guy who did this, put people on the job to try and create this device that actually looks at how you will do an atherectomy. So it's based off principles of shipping and plumbing. So they got this very high-speed screw that cuts through it and then sucks out stuff. And the advantage is you can use it for both, for fresh thrombus, and you can use it for subacute thrombus. It's not that great for calcified. So for in-stent restenosis, for using in grafts and things like that, it works well. This is the Phoenix, the Philips one, which is again supposed to be kind of a hybrid system, rotational, involves a directional and a rotational device. The Jetstream from Boston, which has got, the advantage is it's got two kinds, it's got a blade up and a blade down, which allows you to modify the degree of device luminal gain you want to achieve with that. The orbital atherectomy, which is the stealth device that Casey just showed, which again is good, especially for low profile. And you've got the laser atherectomy, which we do not have, but it runs very slow, but it might be something actually quite attractive. So this is atherectomy, which we've not discussed so far. So what are the challenges with atherectomy? One is embolization. So you either require very active aspiration of whatever is going on, or you want a filter. Restenosis does happen despite immediate plaque removal. This disease is going to want to come back, and by and large, most of us are going to end up using atherectomy in patients who have bad disease. So these are the ones who are bad protoplasm, who are likely to come back with aggressive disease. When you cause so much trauma to a vessel wall, you're going to initiate a massive inflammatory response, which will come back to bite you later on. The vessel damage itself can cause trauma and a dissection or a perforation. And you are going to require concomitant long-term therapy. So this is where the DART philosophy came up. Let's use a drug-coated balloon associated with an atherectomy and leave no foreign body behind, because leaving a stent behind induces constant stress on the vessel wall and increased chances of neointimal hyperplasia. The theoretical benefits are plaque debulking and modification to maximize acute luminal gain, remove the calcium barrier, which allows the drug to move inside nicely when you use a drug-coated balloon, and you minimize the need for stenting. That's the theory of it. When you remove the calcium, you are actually able to use a lower pressure balloon when you do your angioplasty. So you don't have to use high pressure and cause high pressure barotrauma as well. And because you remove the calcium, the drug that you're delivering is able to go uniformly. Remember, everybody was talking about if you've got an eccentric plaque, your drug does not reach everywhere, you embolize more. So when you debulk and you've got a clean surface, your drug-coated balloon is likely to be more effective. So that's the theory of it. So this was the first study, which was a definitive AR study, which was just a subgroup of a larger definitive study, which came out in 2012. Now what this showed is that directional atherectomy plus DCB was effective and safe, but the study was not powered to show any significant difference between the two methods. And trend to potentially better outcomes in severely calcified, longer than 10 centimeter lesions and CTOs. And this is where Vivek will get very happy, because I'm going to show a lot of trials, all right? So ideal trial 2015, and again, all of these are small numbers. All these trials are industry supported. And if you look at the ideal trial 2015, DB atherectomy 12-month, 80% versus 70% for standard balloon. Restenosis rates, DB 21.2 versus non-DB 31. TLR lesions are different. Pacifier study 2016, atherectomy plus DCB. Restenosis at 12 months, 21% versus 45%. Freedom from TLR, 90% versus 76%. East PAD trial 2020, similar kind of results. Why should sirolimus be left far behind if you're looking at paclitaxel? So let's do a LEAP study also, which again, 100 patients, not large numbers when you're going to look for differences. Again, shows DB with atherectomy slightly better than atherectomy with plain balloon. How about if you go into long infrapopliteal lesions, an RCT showing no significant benefit for atherectomy plus DCB in treatment of infrapopliteal arteries, which is the one area where we might have been really keen to use something of this sort. So if you look at a summary of the trials, across multiple studies, atherectomy used with DEB helps to reduce the restenosis rates compared to atherectomy alone. There is a consistent improvement, not very great, but there is when you combine atherectomy and DB. So task 2 recommendation is consider use of DEB for complex fempop lesions, especially following atherectomy or in high-risk patients. So there is reasonable societal evidence for this. But using DCB does not really impact your provisional stenting rates. Your provisional stenting rates with DCB is likely to remain about the same, so you don't really get a huge benefit from that. So who are your candidates where you would want to consider DCB and atherectomies? So ideal candidate, somebody with severely calcified fempop lesions, somebody with in-stent restenosis. But like Vivek was saying, just an angioplasty is not going to be enough. You are going to require an atherectomy device to remove all that neointimal hyperplasia, and then to prevent it coming back, you would look at using a DCB. Complex multi-segment long lesions, high-risk patients. If you've got bad quality vessels, you're not going to get a good quality outcome regardless, but atherectomy probably is going to be your best choice of that. And of course, contraindications for drugs. The other contraindication is, of course, the big bugbear in India. You use a DCB and you combine it with atherectomy, your cost is really going to shoot up, and really speaking, not everyone can afford that. In the longer term, you are potentially reducing reintervention costs. Cost effectiveness, my personal bugbear, all our cost effectiveness studies are from the Western world, and trying to apply a cost effectiveness analysis from the United States of America to the United States of Bangalore is not going to work. So please do not talk cost effectiveness unless you've done it in your own country. So is atherectomy and DCB a marriage made in heaven? Maybe, but even atherosclerosis and calcium were also manufactured in heaven, so you don't know what you're going to do with all of them. So bottom line, if you are going to do an atherectomy, you really should look at combining it with a DB if you want to optimize the results of that. But it is not the holy grail of everything. Thank you.